Without further ado, we're going to hear about the importance of cancer screenings. Dr. Kevin Wood, oncologist from Lucko Pavilion, and he's got other background too, will be talking to us. Welcome, Dr. Wood, and thank you so much.
Thank you, Susan, for the introduction. Hi, everybody. It's good to see you all. It's really a privilege getting to talk to you. I always love these a lot. So thanks for letting me speak with everyone today. I'm going to try to share my screen here. Let's see how I do. Susan, this is okay?
It is. Yep, that's perfect.
Okay. So first, a little introduction about me. I did my training at Cornell in the city, and then out at University of Chicago, and then I came to Valley about 4 years ago. My focus is really on GI cancer, so like pancreas, colon, stomach, and then head and neck cancers. We all kind of specialized here over at Lucko Pavilion in Paramus. But today I'm going to be focusing in on cancer screening, why it's important and what are kind of the most common recommendations. I feel like sometimes these lectures can kind of drone on, so I wanted to make it interesting. So I decided to make kind of a top 10 list of things you should know about cancer screening. So to begin with, point number one, I think the question should be raised, why is cancer screening important? Why should I be doing this in the first place? And I think point one really addresses that. So unfortunately, cancer remains one of the leading causes of death in the United States. It's really actually only second to heart disease as the most common cause of death. So over here on this graph here, you can see the causes of death in the United States in 2020. Obviously, the one that got the most attention was COVID-19 here. But above that, you see that cancer and heart disease were also kind of huge contributors to deaths in the United States. Indeed, there were 1.8 million new cancer cases diagnosed in the US last year and around 600,000 cancer deaths. In the world, so looking everywhere, there are about 18.1 million new cancer cases diagnosed last year and 9.5 million deaths. So it really is a big problem, and finding ways to prevent this or catch this early so that we can treat it and cure it really behooves us to do. This problem is likely only going to get worse as we kind of advance our technology and medicine and everyone is living longer. Indeed, by 2040, it's estimated that there's going to be about almost 30 million new cancer cases diagnosed each year worldwide. So clearly, cancer screening is important. It is not all bad news. Oh, sorry. So indeed, I think this slide is very telling about why cancer screening is so important. So this is looking at the lifetime risk of developing any type of cancer, any site of cancer. And so on the left here, you have males, and on the left or right here, you have females. And the one I wanted to highlight was this all sites, meaning any type of cancer anywhere in your body. The lifetime risk of developing cancer is about 1 in 2 in males and 1 in 3 in females. So kind of scary odds, and it really tells us that at some point in your life, either you or someone you know will likely be dealing with cancer. It's not all bad news though. So we're getting better at catching cancer and also treating cancer. And I think point 2 addresses that. So death rates from cancer have actually decreased quite considerably in the last 20 years, almost by 27%. There's a few hypotheses about why this is occurring. And we think there's kind of 3 main reasons this is happening. The first is screening, which is obviously what we're going to be talking about today. And there's lots of examples of how this is saving lives. I just emphasize one here, which is mammograms. Just a simple annual mammogram has decreased mortality rates from breast cancer by almost 40%, which is huge. We're seeing similar numbers with colonoscopies for colon cancer and pap smears for cervical cancer. So screening clearly works. The second major point is probably oncologists like me are getting a bit better at treating cancer. So we've really had some huge advancements in the last 10 to 15 years. There's many I could potentially highlight, but one I just wanted to briefly mention was immunotherapy, which has really revolutionized cancer in the last 10 years or so. A lot of people haven't heard of immunotherapy, even though there's a lot of commercials on TV for drugs like Keytruda or Opdivo. But immunotherapy is very different from chemotherapy. Chemotherapy I think of as kind of just like poison. It goes in there and it kills the cancer cells, but it also kills your healthy normal cells and you get a bunch of side effects. Immunotherapy is very different. So the way it works, it's an infusion you get every 6 weeks, and it actually activates your own immune system to attack the cancer. So it's your own body that's kind of doing the work, similar to like if you got a bacterial pneumonia, for instance, your body recognizes that bacteria as something that shouldn't be there and starts attacking it and clears it. It hopefully does the same thing with the cancer. This is very well tolerated. In a lot of cases with a lot of different cancers, it actually works better than chemo. So it's really exciting to see, and that's what a lot of the clinical trials are now looking at. The third thing is changes in our behavior. So we're learning some things such as smoking and obesity are huge risk factors for cancer. And so smoking rates are going down, and we're working on obesity with exercise and calorie restricted diets. The one I wanted to emphasize is tobacco, which unfortunately remains a huge problem despite the numbers decreasing. So this is a slide looking at, if you look at this graph over here, US smoking rates, beginning back in the 1940s and then coming to around 2018. And you'll see that smoking really peaked in about the 1950s to 1960s. Indeed, almost half the population was smoking during those years. And in 1963, it was estimated that Americans smoked the equivalent of half a pack per adult per day, which is a lot of cigarettes. It is very concerning. Clearly, these numbers have declined quite considerably. Now, only about 16% of the adult population has smoked in the last week, but it's still a huge problem. So it's estimated that probably around 34 million Americans still smoke. Smoking leads to 85 to 90% of cases of lung cancer, and finding ways for patients to stop smoking is huge. So if you're smoking, you should quit. Before we get into kind of the screening information and screening recommendations, I wanted to emphasize the primary care doctors, because I think they play such a huge role in making sure that patients and you are staying up to date with all of your cancer screening and doing everything right for your health. The way I think about primary care doctors, the way I describe them to my patients, they're kind of like the quarterback in your healthcare team, right? I think it's easy to kind of get bogged down with all these specialists that are looking at just kind of one specific part of your body, but you really need someone who's looking at the whole picture and kind of making sure everything's being done correctly. And that's what the primary care doctor does. They're looking at the whole body, and they're really kind of taking a holistic approach to making sure you're doing everything right and living as long as possible. I just kind of copied from the Valley Primary Care website all that they offer, and they offer a lot. They're really kind of covering everything to make sure you're living a healthy, normal, good life for you and your family. And so if you do not have a primary care doctor, you should have one. And if you do, make sure you're doing your annual visits or semi-annual visits and keeping up with all your immunizations and screening, etc. So I'm going to highlight a few different types of cancer screening today. And the ones I'm highlighting are really shaped by this point number 4. So it's interesting, but in the United States, there's only a few types of cancers that actually lead to the majority of cancer deaths. So this kind of explains that. So this is looking at the most common cause of cancer-related death in the United States. And you see that lung cancer is kind of a huge factor here. This probably accounts for about 1/3 of the cancer-related deaths in the US, which is really scary. And if you think about it, 85 to 90% of these patients that are dying are from smoking. The other 4 big ones are colon and rectal cancer, pancreas cancer, and then breast cancer for females and prostate cancer for males. And these 5 here make up kind of the bulk of cancer-related deaths in the United States. Today, I'm going to be talking about lung cancer, colon cancer, breast, and prostate cancer screening. There's no screening recommendations for pancreas cancer, but I did want to kind of briefly touch on it because clearly this remains a problem in the United States. So pancreas cancer, I think people are learning a lot more about them in the past few years, as a few celebrities like Alex Trebek, for instance, have gotten diagnosed with pancreas cancer. Unfortunately, this is an aggressive cancer. 90% of cases of pancreas cancer get diagnosed when they are already stage 4. And unfortunately, we really lack a strong screening method to kind of evaluate to make sure you don't have pancreas cancer and to catch it early if it does develop. I think this diagram here really emphasizes how deadly pancreas cancer can be. So this top part here is looking at the estimated number of new cases of cancer diagnosed based off specific cancer types, both for males on the left and females on the right. And you see that pancreas cancer, the new cases that are being diagnosed actually really isn't that common. It's kind of at the lower end of the list. But down here on the bottom, this is looking at the estimated number of deaths from cancer. So those patients that ultimately die because of their cancer. And you see that pancreas cancer has moved up considerably. So unfortunately, pancreas cancer is an aggressive cancer that we're still really working on a good way to screen for. I would highlight there's certain patients that we consider high risk, and these are patients with genetic syndromes that put them at increased risk for pancreas cancer, and sometimes patients with a strong family history of pancreas cancer. And in these patients, we're evaluating both endoscopic ultrasounds, which is basically where they put a camera down your throat and use an ultrasound to evaluate the pancreas from the inside, and MRIs, which gives you kind of a detailed picture of the pancreas to evaluate to make sure pancreas cancer isn't developing. There have been a few trials that have looked at using these methods in kind of the general population, so you or me, and unfortunately it hasn't played out as really being promising or helping those patients live longer. So as of yet, there's no kind of good recommendations for screening for pancreas cancer. So let's start with point number 5. We're going to be looking at lung cancer, which, as I said, it's about a third of the cases of cancer-related death in the United States. In the last few years, we have found out that low-dose CAT scans of the chest are a promising screening modality for lung cancer. Let's delve into that a little bit. So preventing lung cancer, I've emphasized this a few times, but I think you can't emphasize it enough. Smoking is the biggest thing, the strongest way to reduce your risk for lung cancer. So if you're smoking, you should stop. If you are smoking, you're at increased risk for lung cancer. And the way to kind of catch lung cancer early, if it does start to develop, is with CAT scans of the chest. So there was a huge study that came out that looked at doing screening with CAT scans of the chest versus doing nothing. And when you did an annual low-dose CAT scan of the chest, it reduced mortality from lung cancer by about 20%. So it caught a lot of these lung cancer cases early where you could still cure them. These low-dose CT scans are very different from CAT scans from the 70s or the 80s, where there was huge doses of radiation being used that could increase your risk for other types of cancer. So they're much, much safer. And the nice thing about it, I don't know if any of you have had CAT scans where you've had contrast, which can often be quite icky and cause diarrhea and make people feel kind of miserable. No contrast is required with this. Here's kind of an example over here of what we see when a CAT scan is done. So I'll kind of orient you guys here, but white is bone. So this is the spine right here, and they're laying down on their back here, and the ribs are coming around here. This is the heart right here in the middle. In black is air. So this is the right lung over here, and the left lung is over here. All these tiny little dots are airways and bronchioles. So these are totally normal. But this huge lump here should not be here. This is cancer, and this is something that this low-dose CT scan is picking up, where we can hopefully just remove it with surgery or maybe do radiation to treat it. A lot of my patients ask about doing chest x-rays, which are much more simple and have lower doses of radiation. There have been numerous studies that have looked at this as a screening method. It is not helpful. It is not adequate. So a clear chest x-ray for patients at a high risk for lung cancer, we tend to ignore them because they're not useful. There are a few potential downsides to lung cancer screening, and I wanted to highlight these before I kind of talk about the recommendations from many of the cancer societies. So a couple of the downsides. The first is false positives. So, as people get older, they're exposed to many different toxins in their environment, pollution, et cetera, going into New York City. And because of that, they can develop nodules and spots and calcifications in their lungs, which can be mistaken for cancer, or you're not sure if it's cancer or not. So you can often lead, in some cases, to these false positives where you need to do biopsies, which also have their own risks, such as the lung collapsing or bleeding or pain at the site where they do the biopsy. So you need to take that into account. Here's kind of an example of how we do these biopsies. So typically we use a CAT scan to guide in the needle from the outside. So this is kind of a similar image to what we saw before, but the interventional radiologists, they do this over at Valley Hospital. They basically use the CAT scan to guide in this needle here and go right to the spot where the cancer is so that they can sample it. Overall, it's actually a very safe procedure, and they do a ton of these over Valley Hospital, but any procedure has risk and they should be discussed before the procedure is done. The other is radiation exposure. So I mentioned the dose of radiation is dramatically less, but there's still a small amount of radiation that you're being exposed to. It's estimated for every 108 lung cancers that are discovered using these low-dose CT scans, probably one major cancer will be induced in a patient by the radiation you're getting exposed to. So something you really need to weigh the risk versus benefits about. And then finally, patient distress. This can often cause some anxiety. So oftentimes I've seen this in a few patients. You get very small nodules or calcifications that are picked up on the CT scan that are too small to biopsy. The interventional radiologists think they would miss if they tried to do a biopsy of it. And in those patients, you just have to watch these spots. You get a CAT scan again in 4 or 6 months to make sure that spot isn't growing. But for some patients, it can cause a lot of anxiety and worry. So it's something to take into account. So these are the current lung cancer screening recommendations. And they're a little bit confusing, so I want to kind of lay it all out here. So the eligible patients, the patients we should really consider doing these in, they're between the ages of 50 and 80 years old, and they've smoked for at least 20 years, basically a pack a day for 20 years or a half a pack a day for 40 years. They are a current smoker, or they quit in the last 15 years. If you meet all these eligibility criteria, then a low-dose CT scan is often considered. It's felt like the benefits probably outweigh the risk. And it's recommended that you do this once a year and that you stop once you have quit smoking for 15 years. There have been a few studies that have found at that 15-year mark, your risk for lung cancer decreases to about that of the general population. But during those 15 years, you need to watch things closely. So these are the current guidelines that we're using here at Valley. The next, I wanted to highlight colon cancer, which is the next most common cause of cancer-related deaths in the US, and talk about the dreaded colonoscopy, which everyone hates. Unfortunately, it remains the gold standard for colon cancer screening, but there are other options available, and I wanted to kind of highlight all of these today so you guys can make an educated decision. So first, before we delve into that, I just wanted to talk about kind of the percentages of patients getting screened for colon cancer throughout the United States. The numbers are pretty dismal. So this is looking at patients over the age of 50 who've had a colonoscopy or some type of colon cancer screening. The guidelines recommend 100% of these patients should be getting screened. We're failing in New Jersey. So about 66% of New Jersey is receiving colorectal screening. And if you think about it, if we can increase this number, the rates of colon cancer and deaths from colon cancer in New Jersey and the US would decline dramatically. So finding a way to increase these numbers is really important. There are a few types of screening for colon cancer that we can consider. So the first are stool-based tests. And these are basically where you're doing studies of the stool. It doesn't require any invasive procedures, and basically you're sending in your stool so they can evaluate either for blood, which is basically what these first two tests, the fecal immunochemical test and the fecal occult blood test, are doing, or something called a stool DNA test, where basically what they're doing is they're analyzing the cells in the stool and looking for mutations in the DNA of those cells that are commonly associated with colorectal cancer. The most common test that there's a ton of commercials on, so a lot of people have heard of, is the Cologuard test, which I'm going to be talking about on the next slide. The gold standard, as I mentioned, remains the colonoscopy. This is by and far the most sensitive and specific way of identifying colon cancer. Sigmoidoscopy I'm going to talk about less today because this is much less accurate at picking up colon cancer. Colonoscopy is the way I think about it. It's basically looking at the whole colon and the whole rectum, and also the very last part of the small intestine. Sigmoidoscopies, on the other hand, really only look at the rectum and the very end of the colon, which we call the sigmoid colon. So it's missing a huge part of the colon, the small intestine, and could miss cancers that are kind of deeper in. The last, in patients that really don't qualify for any of these, that are considered too high risk, we sometimes consider doing a CAT scan and basically looking to look for any abnormalities. CAT scans are not the best at looking inside the colon. They're good at looking at the rest of the abdomen and looking at the liver and the pancreas, for instance, but they're not the best at looking inside. So these other methods are usually considered first. So let's kind of highlight these stool-based tests and talk about the pros and cons of each. So as I mentioned, these first two, the fecal immunochemical test and the fecal cold blood test, are basically looking for blood in the stool. This is a very common presenting sign of colon cancer, but usually initially the blood is microscopic. So you can't see it in the stool if you evaluate it, but these tests can detect this microscopic blood. They're good tests. So the FIT test, for instance, it's an easy test to do. It requires only one sample of stool. So one day, you don't have to modify your diet or change your medications. You just send in the stool sample. And it can detect about 74% of colon cancers. So it can miss about a quarter. Generally, if you decide to go this route, you need testing annually. The next one has slightly lower rates of picking up colon cancer. So that's just a fecal cold blood test. This detects blood in a slightly different way. It's a little bit more obnoxious. It requires 3 days of samples. Basically, you're collecting stool 3 days in a row and then sending it in. This is also recommended to do annually, and it detects about 64 to 80% of colon cancer. The third test, and I think if you're going to go the stool-based route, this is the route I would recommend because it seems to be the best, is the stool DNA test. And the one everyone knows most about is the Cologuard test. As I mentioned, this is looking not only for blood like the other two tests, but also for mutations in the DNA that we commonly associate with colon cancer. It seems to be a little bit better than the others at picking up colon cancer. So it detects about 92% of colon cancers. And depending on your risk factors and your discussion with your primary care doctor or gastroenterologist, generally it's recommended to do this every 1 to 3 years. If the test is abnormal, and I think this is an important fact to highlight, a colonoscopy is always required. That's always going to be the next step if there's any abnormalities found on any of these tests. And I think it's also important to emphasize if you're at a higher risk for colon cancer compared to the general population, these tests really aren't adequate. It's still missing a lot of cases in these patients, and a colonoscopy is still going to be recommended. And by high risk, I mean either a personal or family history of having numerous polyps or having colon cancer. If you have inflammatory bowel disease, like Crohn's disease, for instance, or you have genetic conditions that increase your risk for colon cancer, like Lynch syndrome, for instance. For any of these patients, they should not be doing a stool-based test, and they should instead be doing a colonoscopy. And I think to me, this kind of highlights, because it starts getting a little bit complicated, the importance of having your primary care doctor so you can have this discussion with them so that you can make sure you're doing the right test and getting adequate screening. I didn't put this in the slide anywhere, but the recommendations for any of these screening methods are, in the past, were to start at age 50. However, the incidence of colon cancer is interesting. In the last 10 or 15 years or so, we're seeing that it's starting to be diagnosed at younger ages. So actually, most of the guidelines now recommend starting screening at age 45 instead of age 50, which I think is an important point to highlight. So the colonoscopy, as I mentioned, remains the gold standard. And I wanted to talk kind of about the pros and cons, because most people do not like the idea of doing a colonoscopy. So, you know, the pros. So this is the best way of picking up colon cancer. It's not perfect. It's estimated that it picks up around 98 to 97.5% of colon cancers, but occasionally a very small polyp or an abnormal lesion can be missed, especially those that are very deep inside the colon, kind of farther in. I think the other big pro is that it allows removal of polyps, which is really the prelude to colon cancer. So every colon cancer grows exactly the same way. It starts as a polyp and grows and starts to evolve into a cancer. So this polyp is basically stage 1, and then it starts growing and growing and growing and ultimately becomes a cancer. By doing the colonoscopy, you can remove these polyps before they turn into anything whatsoever. And a lot of these polyps can be missed with any of the stool-based tests that I mentioned previously. I think some of the cons, I think the biggest one is obviously the bowel prep. It's not fun and there's no way around it. So that's kind of the downside that most patients kind of dread. It also requires a little bit of sedation. So for patients that are higher risk with sedation, if they have lung disease or heart disease, this might not be the best option for them. And then finally, the risk is small, but there's a risk sometimes for either perforation or infection. So sometimes you can put the colonoscopy of the camera in, and it can kind of break through the wall of the colon, or it can lead bacteria that's abnormal into the colon and lead to an infection. The risks are small, but I think if you're going to be going this route, it's always important to ask your gastroenterologist about all these pros and cons to make sure you're making the right decision. I wanted to highlight this really great program we have here at Valley, which a lot of people have not heard of, and it's our Fast Track Colonoscopy program. This program's great, and it makes colonoscopies very, very easy. I think for a lot of my patients, getting them to do a colonoscopy in the first place and convincing them that it's the right thing to do is difficult. And then in the past, once we convinced them, getting them in to see a gastroenterologist and making sure their insurance was covered, and then getting the colonoscopy scheduled, it was just this huge hassle with a lot of obstacles. This kind of bypasses all that, so it makes it much easier for you guys. So if you go to the Valley website, you can also see this, but basically you just call this number here and you talk over the phone with a nurse navigator. And they kind of go through your whole history and make sure you're eligible and don't have any kind of high risk criteria like the lung disease or the heart disease that we mentioned before. As long as you don't, they schedule the colonoscopy. You don't have to make a doctor's visit. You don't have to work with any insurance issues, and the colonoscopy gets completed. So it makes things much easier. So I think this is a wonderful program. We've done a lot of colonoscopies because of this, and something everyone should look into. Bottom line, however, for colon cancer, it remains a very, very common cause of death in the United States, and almost all of these cases could be prevented with good screening. So screening is vital. And I really think colon cancer, especially the screening, gets a little bit complicated just because there's so many options. So this is really where a discussion with your primary care doctor should be had about which option is really best for you. Next, breast cancer. So as I mentioned before, mammograms are amazing at reducing mortality rates from breast cancer in women. It's estimated that it can reduce mortality rates by about 40%. Unfortunately, breast cancer remains very common. This is a very prevalent problem, as most people are aware. It's estimated that women have about a 1 in 8 chance of developing breast cancer at some point in their life. Indeed, in 2021, it's estimated there's about to be almost 300,000 new cases diagnosed, and around 43,000 women will die from breast cancer. The mammograms are very vital. A lot of the guidelines, they have slightly different twists on what they recommend. At Valley, we follow recommendations from the National Comprehensive Cancer Network. We think this is kind of the most conservative and the safest route to go. And the recommendations by this network are that for average risk women, we recommend an annual mammogram beginning at the age of 40. And you continue that for as long as you're in good health. So there's no kind of age criteria after that of when you would stop. It's just as long as you're healthy. In certain high-risk women, MRIs are considered. So similar kind of like pancreas cancer, like I was talking about before, genetic conditions or a strong family history or a personal history of kind of breast cancer in situ or kind of the early stages of breast cancer, MRIs are sometimes considered for these patients. And again, it's kind of a discussion with your primary care doctor to make sure you don't meet this high-risk criteria. In patients where there's a question of whether you might be high risk or low risk or normal risk, we actually have a high risk breast screening program here at Luckow Pavilion, which is where the cancer center is, where you meet with our breast surgeons and they make sure we're doing the right screening for you. So something to consider if you have questions about that. Next, prostate cancer, which is a big problem in men. There is a good screening method for prostate cancer. It's called the PSA test, which we'll talk about here a bit today. And there's pros and cons about that. So a lot of the guidelines are kind of wishy-washy on if you should really be doing this or not. And again, it gets a little complicated, and I think it's worth a discussion to see if it's the right test for you or not. So the test, it's the prostate-specific antigen lab test. So it's just a simple blood test is the best mode of screening. And so what this test is, the way I think about it, prostate cancer cells, they release a hormone into the bloodstream that you can measure. And that hormone is this PSA level. So you can check this level, and if it starts to go up, it suggests that there might be prostate cancer present. And it's actually a very sensitive test. I think the good news before we talk about this for men is that digital rectal exams are actually no longer recommended by most guidelines. You no longer have to have the digital rectal exam. If you decide that screening for prostate cancer is right for you, you only need to do the simple blood test. If you decide to be screened, and we'll talk about the pros and cons of this on the next slide, we recommend annual screening. So for average risk patients, we begin at age 50 and continue each year after that. For high-risk patients, you should start a little bit earlier at age 40 or 45, depending on which guideline you're looking at. By high risk, I mean African Americans, which have a significantly higher risk of developing prostate cancer, or if you have a family history of prostate cancer or prostate cancer being diagnosed at an early age. So why the pros and cons? Why is this test kind of unclear if we should really be doing it or not? So prostate cancer is an interesting disease. So almost all men at some point, if they live long enough, will develop prostate cancer. And for the vast majority of them, they will not die from it or have problems from it. So the question is, should we really be doing a test to evaluate for this if it could possibly never cause any problems? So the pros of doing this PSA test, first is increased detection. As I mentioned, it's a very sensitive test at picking up prostate cancer. So this number starts to go up. It should lead to further testing because there's a chance there might be prostate cancer present. It does decrease the rate of spread of prostate cancer. So they looked at either doing this PSA test once a year versus doing nothing. And they found that the risk of developing a stage 4 prostate cancer, meaning prostate cancer that had spread to other organs in the body, was decreased by a little bit, by about 0.2 to 0.3% per year. So not dramatically high numbers, but there was a statistically significant improvement. There was also a decreased risk of death from prostate cancer when you did this PSA test. It was small again though, however. So for every 781 men that are screened, only about 1 cancer death was prevented. What are the cons? So the first is false positives. And I mean something slightly different here. You know, like I said earlier, oftentimes prostate cancer can be an indolent disease, and in some patients never cause any problems. But once you kind of pick it up with this PSA test, it will likely lead to some form of treatment with either radiation or surgery, which can often lead to its own problems and can down the road. So it can really have an impact on quality of life. So something to consider. Also anxiety. If this number starts to go up, it can lead to a lot of anxiety. And I think it's important to emphasize that not only prostate cancer can make this number go up, but really any irritation of the prostate itself. So if you get a bladder infection, for instance, it can make this number briefly go up, which can lead to this anxiety. All of this, when this test becomes positive, it can often lead to a prostate biopsy, and kind of similar to doing the lung biopsy earlier, there's always going to be a risk with any procedure. So something to consider. And then all of this is due to overdiagnosis. So as I mentioned, a lot of these patients may never have problems from their prostate cancer. So it's really kind of a thoughtful decision to decide if this test is right for you or not. Number 9, so for patients with a strong family history of cancer, genetic counseling should be considered. And I get asked this question a lot. So genetic counseling, you know, it's interesting. It's less cases of cancer than you would think, but about 5 to 10% of cancer cases are hereditary, that are passed down because of some mutation, genetic mutation in the family. I got this information here from the Valley Genetic Counseling website. We actually have genetic counselors over here at the Cancer Center who see a lot of our patients. They're really wonderful and great. And patients we typically recommend for getting screening are if you have several relatives with cancer, a close relative with cancer at an early age, a relative with more than one cancer, or a relative with a rare unusual cancer. And again, these guidelines are a little bit vague, so this is a discussion to be had with your primary care doctor or one of your other specialists to see if genetic counseling is right for you, if it's something you're wondering about. For patients where there is a cancer diagnosed in the family, usually we prefer to test the affected family member first. Meaning if your mom was diagnosed with cancer, for instance, we would want to test your mom to see if she has any genetic mutation. If she does, then we would then start testing the other family members. So ideally, we would test the family member with the cancer. We have a really strong program here. So we're affiliated with kind of two very strong genetic counseling centers. The first is the Strang Cancer Prevention Center, which is actually the center that developed the Pap smear, which has had a huge impact on lowering the risk of cervical cancer. And we're also affiliated with the Cornell Medical Center. So if genetic counseling is considered, usually I recommend the genetic counselors here at Valley because they're very strong. And the first thing they often do is this family tree here, where they really go through every detail of your family history and see which family member had what type of cancer, so they can decide what accurate testing they should be doing and what genetic mutations they should be looking for. Finally, number 10, if you do get diagnosed, we're here to help you. So this is our cancer center here. It's called Luckow Pavilion. It's over in Paramus. The new Valley Hospital is being built right behind us, so a very convenient location. I copied these program listings from the Luckow Pavilion website, but I think it's important to highlight. I think one of the strengths with our oncology program here is we've all become very subspecialized, which I think you need to do with cancer. You need to know kind of every single detail of your specialty and the type of cancer you're treating. So for instance, we have a breast cancer program where they basically only treat breast cancer and really focus in on that. And like I said before, me and Dr. Casper, Casper, we lead the gastrointestinal cancer program, and then I focus on the head and neck cancer program as well. So we're here to help if you need us. I'll end with a picture of the new hospital that's being built across the street and saying thank you.
Okay, thank you so much, Dr. Wood. It was so comprehensive, and it is some reminders to me. I'm sure to all of us. Just one question. Can you tell us a little bit more why digital rectal exams are no longer a recommended screening tool? Is there any particular reason?
Yeah, so it was not very accurate at picking up cancer cases. So the reason is with the digital rectal exam, you're only able to palpate kind of the lateral and anterior part of the prostate. So there's a large portion of the prostate that you're not able to feel. And we found that only around 60% of cases were being picked up. So a lot of cases were being missed.
Okay. And just one more, have you found any differences in cancer or cancer treatment since COVID? Has anything shifted that you're aware of?
No, I think the unfortunate thing that we're seeing is, last year when things were really scary, a lot of patients weren't seeing their primary care doctor and weren't getting any type of cancer screening or getting any kind of screening whatsoever. And so unfortunately this year, I think a lot of oncologists are picking up that we're seeing a lot of kind of more advanced cancers, which is unfortunate. I think, again, emphasizes the importance of cancer screening.
Well said. Absolutely. Well, thank you so much again.